Hello, and welcome back to the Oncology Brothers podcast. I am Rahul Gosain, a practicing community medical oncologist, and along with my brother, co-host, and also a community oncologist, Rohit Gosain, today we're thrilled to touch on a very critical topic, palliative care. When delivering cancer care, we often talk about if our interventions are going to make our patients live longer or better. However, with the topic of palliative care in mind, I really believe that we can help our patients live longer and live better. To cover this, we're joined by two world-renowned physicians, Dr. Janet Abraham from Dana-Farber Cancer Institute and Dr. Ishwaria Subbiah from Sarah Cannon Research Institute. Janet, Ishwaria, thank you so much for joining us.
Happy to be here.
Such a pleasure. Great to be here.
Janet and Ishwaria, welcome. Both your work has been instrumental in advancing care, particularly in palliative care. Despite multiple studies, palliative interventions, we have been showing that patients, in fact, do live longer and better. However, the struggle from oncology field has been questionable because of the mass adoption of really relying on this in early intervention of palliative care has not been well adapted because of is it patient hesitancy, lack of appreciation from treating physicians, or rather lack of resources. Janet, starting with you, can you lay some foundation? What is palliative medicine and how things have rather changed in past 5 to 10 years?
Well, palliative medicine has been said to be by Diane Meyer and Capsy, and I agree with this, is an extra layer of support for patients and their families, and also for the oncologists and their offices, I would add. I think that the word palliative means hospice to many patients and feels like it's giving up. And internationally, palliative definitely means giving up, whereas supportive tends to mean something that goes along with treatment. So internationally, it's called supportive care in cancer. And there's been a big debate in the US about whether palliative should change its name, perhaps, to supportive care in cancer. I think that the name has been a barrier. Dr. Barrera has shown that if you call it a supportive oncology team, you get patients referred earlier. But the other aspects you also mentioned are very relevant. There are not enough oncology palliative care practitioners. The recent data shows 60% of community oncologists don't have a palliative care partner. There are only 7,600 or so practicing palliative care clinicians, and as we said, 26,000 oncologists. We can only see about 10 people a day. You see a minimum of 20 probably. So there need to be new techniques and new ways to be part of the workflow for an oncology practitioner in the community to incorporate palliative care techniques and skills into their practice in a seamless way. That's what we need.
Janet, thank you so much for touching on that. You brought up 60% of community oncologists don't have access to palliative care. That number is huge, but being in the community settings, I'm not shocked to hear that. And then I love the idea of maybe having a different title to what we provide, supportive care, because right now there is that stigma around palliative care and hospice. And these services are not the same. They can coexist, but they're not the same. And this field has shifted over the years with its primary focus on end of life to now integrated approach on longevity and quality of life. Ishwaria, can you touch on this for our listeners? How this field is changing, and now with that idea of supportive care, what exactly are we looking at?
I mean, palliative care at its heart is symptom management at any point in a person's illness journey. And so in that way, it's there to provide that synergistic support to the disease management that a person gets, whether it's for cancer, whether it's for heart failure, or really any other condition. And so many people may have crossed paths with palliative care, whether it's in the family or friend or a loved one, in the context of end-of-life care. And so that perception that carries throughout their lived experience is purely because that's what they may have been exposed to. The reality is once people get into the palliative care clinic or supportive care clinic, and they see what's actually offered to them, holistic symptom management for the whole person. I can pick any clinic day and I will at least have a quarter to half of the people say, oh my gosh, I wish I'd seen you earlier. Every single time it happens. And it's through no fault of anyone. It's purely just the reality that we're reconciling with as a palliative care community is how do we make sure that there's enough awareness of what it is so that the patient, caregivers, and their healthcare professionals can make a shared decision on whether a referral is right. It is one more appointment on your on your list. It's one more thing to do. So you have to make sure that it makes sense to bring in another team. And then to highlight a point made earlier is we as a community and in partnership with various health systems, cancer centers, we have to make sure that the pathway for receiving palliative care is there. That's not a responsibility I would put on any individual oncologist, is to set up the system in order for there to be a seamless referral. I spent the first half of my career in Texas, and I can tell you that for me, referring to palliative care was just entering an order in the EMR and then I move about my day. And that's because someone had gone through the trouble to set up a palliative care department and a clean pathway for referral, a well-resourced department with multidisciplinary personnel on site. So there's a call to action that's centered heavily around implementation science that should be said in the same breath as any primary evidence that we would quote. We have to make sure that access to palliative care is there as a overarching oncology and palliative care community, and also as leaders in our respective organizations. That's going to close that gap between the evidence and adoption to real world practice.
Absolutely.
Thanks for mentioning that, Ishwaria. You brought up some very key concepts, or rather these words, symptom management. And Janet, you mentioned supportive care. This is exactly what's improving the quality of life of our patients and their family. Janet, from your standpoint, how have utilization of palliative care changed the outcome in terms of cancer, whether that's quality of life or survivals particularly?
Well, the outcomes have been shown to improve, unfortunately, somewhat in limited populations. I mean, certainly with lung cancer patients, it's very clear that people live longer and better. When Dr. Tamil repeated that study with GI cancers, maybe because the drugs for GI cancers aren't quite as revolutionary as the ones for lung cancers, she wasn't able to reproduce that finding. But in my own clinical practice, which would not be amenable to a study, without symptom management, people won't take the curative drugs. And without their pain being controlled, you can't give them the drugs. Many of the consults we get from the Dana-Farber oncologists for inpatients are to deal with their symptoms so they can be outpatients again and get their curative therapies. So that sophisticated pain management, management of nausea and vomiting, management of delirium, there are just so many things that these drugs now cause that can be brought under control, but you need experts to do that. And I worry that, as you said, even telehealth, which is useful, you have to be connected to a hub and spoke kind of system like MD Anderson, I'm sure is, and the Mass General program, I'm sure is, where you have relationships with oncologists so that you can do the video conferences, which I think really might help this a lot. As I mentioned, we're doing some research sponsored by the NIH, which would give a standalone program that could be added to any electronic health record that would provide symptom management 101 through using consensus-based algorithms that are programmed. And as you said, implementation science is the next step that we are using, because now we have them all programmed and we have NIH experts in implementation science to see how we get them into a big health system, get them adopted. And if they work there, then they could be moved out to the community research settings where all the symptoms that are common to cancer patients could be addressed with this program because it has not just what the level of the symptom is, but what to do about it. So I think we need, as you said, if we don't have enough people, we need other creative solutions, like something you plug into your EHR, tells you what the symptom is and tells you what to do about it. I'm very hopeful for that.
I think that's exactly the key there. And especially what we saw at ASCO too, where telemedicine and live meet in a person still about serves the purpose of quality of life, the prolongation of life there for family and patients. Ishwaria, you'd like to add something here?
Well, we have to recognize that as subspecialists, there's never going to be enough human bandwidth to meet the need. And you can pick any specialty you want in medicine, and you can pick general medicine, primary care. There really will not be, there has not been in the past, at least. I'll be a little hopeful for the future, but still, we have to operate on the assumption that we need to be creative and
Absolutely.
really have innovation drive how we practice medicine. And that's
Very
practically
true.
blasphemous to certain audiences. And that's because in the same breath that we say innovation, we have to say scalability and sustainability.
Very true.
And so innovation in the absence of scalability and sustainability is a waste of somebody's time and money. And so what we're faced with as a field is truly integrating components of technology that still align with the core values of the field. And it is possible. And that's what so much of the work that was presented at ASCO this year and previous years has shown, is that fear of losing the humanism in medicine is something that can be mitigated by thoughtful integration of technology into care delivery. And so in that way, it's certainly ensuring there's enough expertise in palliative care across the country, enough expertise as subspecialists, enough expertise in the primary treating teams, whether it's oncology, whether it's cardiology, whomever. Symptoms are everybody's lane, frankly. Symptom management is everybody's lane. And it's also ensuring that we build in scalable models of needs assessments so that we know who's needing attention when.
I thought that was part of the advantage of Dr. Temmel's presentation. And the other presentation, I think it was from Duke, that talked about who really needs a palliative care consult, using a risk model and sorting people into high to lowest risk for needing the palliative care consult, if that turns out to be validated and is shared. But a low-tech thing would be for all fellowship programs to teach Palliative Care 101, to have that be a core, not just symptom management, but communication. And that's part of what we do. When I see someone in the stairwell who says, I have 3 more DNR conversations today, at least I can support that person. And we can support them with the training they need so they feel that they have the skill coming out of fellowship to at least do the basics, which they're going to do every day, every week. I did anyway.
Yep.
And nobody told me how to do it either.
And we're doing that every day in our clinic, right?
Of course
Janet, you brought this up, that it's failure of the medicine rather than failure of us. I think that every single time there's a patient that we lose, I take a step back and look at it saying, what could I have done different? And that blame goes on me rather than saying, well, we just need to do better in terms of the medications we have. And arguably right now we were talking about whose lane is this? Starting with residency or fellowship, Ashura, you brought this up. It's everybody's lane. We need to change that narrative and get everyone involved from the get-go. Because here, when we're addressing with palliative care, supportive care, is just not the physical aspect, but the emotional and their spiritual needs, right? Ishwaria, more recently, what are some of the most effective approaches or techniques that you have found that help your patients through palliative care that I can take or think about in the community?
In the conversations that I have with my patients, we talk about the importance of addressing symptoms and the importance of having a team who's dedicated to their symptoms. And in that way, the time that we would have for an oncology clinic visit can be dedicated heavily towards the disease management with an emphasis on the symptoms and side effects of their experience. But when I present palliative care consoles as an option to patients, it heavily emphasizes how there's a multidisciplinary team there to help them and their family and to help me, so that it's truly a partnership and taking care of the whole person to have that dedicated time. The second element is when we're introducing difficult topics like advanced care planning, normalizing it, kind of bringing it down a few notches. We need to bring ACP down a few notches. Your family should know how you feel just conceptually. You don't even have to put something on paper. Just conceptually, they know how you feel about life support, how you feel about, if you need to be brought back to life, and those conversations allow for that flexibility in decision making, right? There's no boxes to check here. It's conveying the flexibility in decision making. So when we present it to patients, when I talk about advanced care planning to patients, I'm like, everybody in this room, we need to be sharing with our loved ones how we feel as a whole.
And sometimes an easier way, I was just going to say, an easier way into that for the oncologist perhaps is the hopes and worries conversation. That what are your hopes and what are your worries?
So talking about the exact words and definition and script one should be using, Janet and Ishwaria, how does that conversation with you takes place when talking to patients and their family, or at least talking about introduction of this topic and maneuvering on from there?
Well, I think we have to mention that in different languages, it's a different conversation also. So that, for example, in Spanish, we have a lot of Spanish-speaking patients. It's not cognate. The word hospicio does not translate to what we mean by hospice. And what the interpreters have taught me is to describe what the services are and then say, this is what it's called. So I do that in English now, too. I'll say, you've been through a lot, and your oncologist feels that at this point, she told me that the burden of the therapies, at least for now, might outweigh the benefit. But she wants to stay totally as part of your care. She will always be your doctor. She wants to bring more services in for you and your family that can improve your pain control, make it possible for you to stay at home. We'll see whether a break from the therapy would make you strong enough to get a new therapy that might be less toxic. For right now, though, usually I'm doing this with the oncologist next to me because they want me to do this. I'll say, but she would never do anything that would shorten your life. That's why she can't offer a new therapy right now, because she's so concerned that it would shorten your life or provide a complication that would just be unacceptable. But in most of the cases that I talk with, that's what the oncologist has told me, because talking with your palliative care colleague ahead of time to have these questions answered is really helpful, because then you know that you're saying what they already think. And then when the family says, but how can she give up on me? And she sort of gets a kick in the solar plexus. The palliative care person can say, she would never give up on you. She will always be your doctor. You don't get a ticket to her office by taking treatment. You wouldn't believe how many people are shocked by that phrase. And the oncologist is shocked at the idea that they would give up on the patient, but the patient assumes that unless they take treatment, they don't warrant the time, that precious time of their oncologist.
I echo many of the same concepts, right? The treatment options that are out there, I'm afraid that they will hurt you more than help you. And I'm afraid that not only would they not help you live longer and better, but that they actually may take time away from you. And so by approaching it that way, it's so crucial to ensure that the person you're taking care of, that they recognize that they're not leaving something on the table, that they're not turning their back to a good treatment. There's an element of FOMO that goes into, in a very serious way, that goes into these types of decisions. And you see it on people's faces. There's an agony there from, what if this is the one? What if this is the one? And I haven't been at that juncture of life myself. I'm thankful for that. So I can't even for a second judge or even imagine what that person is going through trying to make some of these decisions. The info that we would share as oncologists, as palliative care clinicians, is the evidence and the interpretation of the evidence to help them make that decision, right? The treatment options that are there, I don't see any of them as home runs, and I'm worried that they actually may take time away from you. So there are support services that can be provided to you in your home. You don't have to leave your house for doctor's appointments. Hospice care comes to you in your house, and they are there for you 24/7 and your care family 24/7, and they take care of you over time as needs may change. And so they're not the people some people may call them at the last, a minute before their last breath. But the fact is you can have your healthcare team come to your house through hospice. So kind of really just taking it head on, but normalizing it, not beating around the bushes and not feeling uncomfortable in any way. We have to, what we project, patients pick up, right? And so if we're skirting around something, they see that. And they see you skirting around, but they may not know what it is you're skirting around. I think you're dying. I mean, like, just get it out,
That's really powerful. And I think that you hit on such an important thing, which is if you don't feel that you have failed this patient and you feel that you have something to offer them, which is supportive care and the best possible time so that they can tie up their loose ends, they can talk to their family, they have the time they need. If you honestly see that you're giving them the time, that precious time that they need, then your whole body language changes. As I'm seeing you online now, you just glow with that. I have this really good thing to offer. I wish it were the treatments. It's not those treatments. They would actually be bad. But I have this other really good thing to offer. And your whole body language says that it's a real important thing that you're offering them and that you will continue to be with them. And I agree completely that once the oncologist is able to process before they see the patient and family that grief with other people in their office, maybe the nurses, maybe their office manager. I can't believe I'm going to see so-and-so today, and I'm going to have to explain that the treatment would be worse than not treating, and I'm going to have to talk about, and the office says, you have done everything you can. Nobody could have done more. Going in with that confidence, perhaps with that nurse or with somebody that family knows, so that you can leave and they can then continue the conversation with that person. Ishwaria, I think, hit the nail on the head. That's makes a huge difference to that patient and family. It's very nonverbal and it's very clear.
And often a phrase that I've used, that I don't have a crystal ball on how much time we have, but on my end, I want to make sure that we're doing everything that you're comfortable and you're with your loved ones. And one thing to often bring up during this conversation is hospice support is not only for our patients, but the resources that are available are critical for the whole family. It is about supporting the patient and the family through one of the most challenging times.
If
Well, this
people
has
do
been
ask for a time frame, it is helpful to say that I worry that,
time
I
is
wish
short.
you had years.
Yes.
I worry it's a matter of months. And hospice can care for people
Yes.
who have months to live, something like
Yes.
that,
Absolutely.
if they ask.
Yes, no, absolutely. Because again, you want to, at least from your perspective, be able to talk about it. Is it usually days to weeks, weeks to months, or months to years? Because again, that is preparing, and exactly to what Ishwaria, you were saying, instead of running around, you're being honest in your personal, professional opinion here.
Exactly.
By giving patients appropriate responses to the difficult questions, we're actually allowing them to reclaim some control of their experience. Right?
Absolutely. Wow, we've covered a lot here. Janet, Ishwaria, thank you so much for sharing your expertise on such an important but often misunderstood aspect of cancer care. Thank you so much for this incredibly insightful conversation. For our listeners, let us recap some of the key takeaways from this conversation.
Today, we had an enlightening conversation about palliative care with Doctors Janet, Abrahm, and Ishwaria Subbiah. We explored how palliative care has evolved from being associated primarily with end of life to becoming an integral part of cancer care and helping patients both live longer and better lives. Our discussion highlighted the importance of addressing not only the physical but also emotional and spiritual needs of the patients.
We also touch on the stigma surrounding palliative care and hospice, emphasizing that these services are about enhancing quality of life at every stage of cancer journey. Palliative care can make a profound difference in patients' outcomes and their overall well-being. Thank you for tuning in. As always, we really appreciate your support. We are the Oncology Brothers.